Good afternoon, everyone, and thank you for joining us for our Dr. M. Alfred Haynes lecture. Today we'll start with welcome and introductions. We'll move on to the lecture and then a short question and answer session, and we'll move on to closing remarks. So as you all may know, with funding from NIMHD, the Urban Health Institute really serves to support the research infrastructure at Charles R. Drew University of Medicine and Science in these 4 key areas. Now, our Dr. M. Alfred Haynes lecture series is really to honor the legacy of Dr. M. Alfred Haynes via a CDU curriculum that elevates, promotes awareness, and engages discussion around health disparities, social determinants, policy, and educational approaches for the advancement of wellness in underserved and under-resourced communities. These are our objectives on the screen. Now, it is such an honor to introduce you to our featured speaker for today. Dr. Helena Hansen is a psychiatrist anthropologist. She is currently a professor of psychiatry and chair of the research theme in translational social science and health equity at UCLA's David Geffen School of Medicine. She is the author of 3 books, Addicted to Christ, Remaking Men in Puerto Rican Pentecostal Drug Ministries, Structural Competency in Medicine and Mental Health, a case-based approach to treating the social determinants of health. And she's currently working on Whiteout, How Racial Capitalism Changed the Color of Heroin in America. She has received numerous awards, including an honorary doctorate from Mount Sinai School of Medicine in New York and election to the National Academy of Medicine. Please join me in giving a warm welcome to Dr. Helena Hansen.
Thank you so much for that generous introduction. Let me see if I can share my slides.
Absolutely.
Okay. Are you seeing them?
Yes, we can see your slides.
Okay. There we go.
Perfect.
So I want to tell you that I've been studying the intersection of race with addiction medicine for 2 decades. And actually, before I launched into this, I just want to thank deeply the Charles Drew Selection Committee for the Alfred Haynes lecture, because it's such an honor to be with you. And I am quite an admirer of your work in community engaged and community participatory research on health inequalities. I've learned so much from my colleagues at Charles Drew before and after landing here in Los Angeles on the UCLA faculty. So I want to make sure to say that. And then I'll go into explaining that my work has really been at the intersection of race with addiction medicine for the past 2 decades. And I started this work at a time when the media was publishing stories about the surprise of white suburban and rural opioid addiction. So my study quickly turned to how the US opioid crisis came to be seen as a white problem. And since that time, unfortunately, the plot has thickened. And so I'm going to just go through my disclosures. I have none, and the learning objectives for this time that we have together, and go to this, which illustrates that since the onset of COVID, our already record-breaking overdose deaths in the US that exceed that of any other country in the world went up by 40%. So under COVID, overdose rates only went up from already record high levels. And the overdose rate among Black Americans exceeded that of white Americans for the first time over the past 20 years. And you'll notice from this graph that was prepared by Joe Friedman, a UCLA graduate student that I work with and who I think has presented many times at Drew himself, you'll see that Native American overdose deaths were already higher in many places in this timeline than white American deaths, but that's something that was never discussed in the media. And so the idea that opioid overdose is a white problem always has been a fallacy, but it's even clearer at this point in time. And so I want, though, to point out the obvious fact that what makes the overdose crisis of the past 20 years different in many people's minds is the way that the white identity of the sufferers has been highlighted in media and in policy. I'm going to approach this this topic from an angle of race and health, from an angle that's unusual for us in medicine, by examining the mechanisms of whiteness. I'm going to share a case study of the hidden but active maintenance of white exclusivity in medicine as the cause of what we call health disparities among quote unquote underserved minorities, groups typically described in a passive manner as lacking access to care. So whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. So it involves the mutual racialization of drugs and people. So drugs can be white, as in targeted to white people, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. I first encountered office-based medication for opioid dependence in the late 1990s when I was a medical student. I was working on early clinical trials of buprenorphine, which would later be manufactured with naloxone and commercially branded Suboxone. And my attendings, my medical school professors, were very excited about buprenorphine. They said it was about to change the culture of medicine by defining addiction as a chronic disease, treatable alongside diabetes, hypertension, and asthma in the same clinics, that is primary care clinics, and in the same way with long-term pharmaceutical maintenance. So this caught my ear as an MD Ph.D. student in cultural anthropology and medicine. And I had to ask, what could it mean to change the culture of medicine? And what would drive a change like this? As it turns out, my attendings were absolutely right. In the course of my career, I witnessed a profound change in the way that clinicians frame addiction. My field of addiction treatment swang from a drug-free philosophy in the early 1990s to opioid maintenance as first line of treatment by the 2000s. And as I completed an addiction fellowship and took a faculty position in psychiatry and anthropology, I also documented stark differences between buprenorphine patients and methadone patients by race and class. So what began as a study of the culture of medicine became a study of how the opioid crisis depicted in this graph came to be seen as white, ironically at the same time that racially targeted drug war policies led to mass incarceration of Black and Latinx Americans, giving the US the highest incarceration rate in the world. That's depicted here, with a peak actually as recently as 2008 in the incarceration rate. So I'm going to give you an analysis from my forthcoming book on opioids and race based on research supported by the National Institute on Drug Abuse, the Robert Wood Johnson Foundation, the American Psychiatric Association, and the New York State Office of Mental Health. And I want to point out, as many of you know, that narcotics have long been criminalized through association with marginalized racial groups. So this is, from 100 years ago, Chinese opium dens, cocaine-crazed Negroes in the South that were attacking their work supervisors, 1914 New York Times, Mexican marijuana madness. So these were images that were used to pass prohibitionist drug policies that we have seen the impact of today in the form of mass incarceration on drug charges. But what we rarely think about is that alongside these racialized illegal drug markets, the symbolic association of white middle class markets with legal narcotics, prescribed narcotics, has legitimated widespread prescription of narcotics among white middle class consumers. Including post-World War II epidemic overdose from barbiturates and benzodiazepines that haunted white middle-class America. They were using quote unquote suburban mother's little helper. We rarely ask how a drug can assume whiteness in a pharmaceutical logic based on race. And yet the process of pharmaceutical whiteness is at the core of the widely asked question, at least as recently as 2015, when this landmark article came out. Why is while the life expectancy of almost every other racial group is rising, the life expectancy of whites, at least in 2015, had been falling for 2 decades. And how did overdose become the primary immediate cause of excess death for white Americans? So I want to go beyond the received wisdom that unemployed white Americans in the post-industrial Rust Belt turned to opioids for solace. So that might be true, but it begs the question of why opioids, why white Americans, and why in this moment of time. I argue that the current generation of opioids were designed initially to have white racial identities, and that in our stratified healthcare and justice systems, the social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming white Americans. And key to this story is an unrecognized form of ethnic marketing that, because it targets white Americans, works by not marking itself as racial. It's a story that's invisible by design, and it was only through years of observation and interviews with key actors that I was able to unravel the threads. So I've observed drug policy and addiction science meetings and clinical interactions for over a decade. I've interviewed over 200 addiction scientists, treatment advocates, pharma executives, policymakers, administrators, and prescribers. And so I want to start the story that I have put together with this. It's a study of Suboxone, otherwise known as buprenorphine. And it's easiest to see its racial identity by comparing it to its predecessor, methadone. So this is a bar graph from the first nationally representative sample to compare buprenorphine patients to methadone patients by race and class. And then I later I confirmed these patterns by mapping buprenorphine versus methadone patients where they live in New York City. And then a colleague, David Schreiger, did the same mapping in Los Angeles, confirming the same principles. And then in 2019, another nationally representative study published in JAMA Psychiatry showing that to date, white Americans with opioid use disorder who see a clinician are 3 to 4 times as likely to get buprenorphine as a treatment than Black Americans, with the most common payment method being out of pocket for very, very expensive medication, followed by private insurance, and much further down the line, public insurance like Medicaid. So what we don't know from graphs like this is by what process did buprenorphine and methadone gain their racial identities? And for that, we have to go back in time. So let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. You know, actually the Watts Rebellion led to the formation of Charles Drew University. The unemployment rate for Black Americans is twice that for white Americans, and organized crime gained control of Asian heroin imports, recruiting a sales force from Black and Latinx inner cities. Meanwhile, Rockefeller University metabolic researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency analogous to insulin deficiency and diabetes, he publishes with colleagues findings from the first clinical trial of methadone maintenance. The study's subjects are African-American heroin injecting men from Harlem, and its outcomes of reduced arrest and increased employment at 6 months brings it national attention. By 1970, news of methadone as a pharmacological answer to urban heroin reaches President Nixon. And Nixon appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. Nixon targets inner city Black and Latinx Americans, as well as returning Vietnam veterans, with methadone, his major weapon in his war on drugs. To prevent diversion and street sale of methadone, the DEA regulates methadone clinics directly, requiring daily observed dosing and regular urine testing. And due to NIMBYism, not in my backyardism, and community resistance to these methadone clinics, they're actually located in marginalized neighborhoods, remote from medical services. So they've long had this quasi-medical status, actually not fully integrated into clinical medicine. So let's fast forward to 2002. A new kind of opioid problem has developed following Purdue Pharma's aggressive marketing of OxyContin as a quote unquote minimally addictive pain reliever. Most of the newly dependent people are white, many of them middle to upper income. And the FDA has just approved the synthetic opiate buprenorphine, commercially packaged with naloxone as Suboxone, for maintenance treatment of opiate dependence in buprenorphine certified doctors' offices. So pharmacologically similar to methadone in that it's an opioid that blocks opiate receptors in the brains of addicted patients. Buprenorphine can be prescribed monthly for use at home, while methadone is still restricted to DEA regulated clinics and directly observed dosing. Office-based buprenorphine represents a reversal of national policy. It's the first time since the 1914 Harrison Act that private doctors are permitted to use opioids to treat opiate dependence. And to accomplish this, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. In other words, buprenorphine pharmacologically in the same drug class as methadone had to be whitened. Okay, and so I am going to attempt a multimedia presentation here by showing you a public service announcement that that really tells the story visually of how the pharma industries did this. So I'm going to, okay, so I may not be able to do that. And in its place, I'm going to show an image from, I'm going to show an image from the ad since I can't show the video very easily. Okay, so let me go back to my screen share. Okay, hopefully you can see the image now. Okay, so this is Mike. He's seated in his Ohio diner, flanked by American flags, as you can see. He's talking about returning to coaching his son's baseball team and singing in his church choir after buprenorphine rescued him from an OxyContin habit that he developed following a back injury and treatment for pain. So we could spend a lot of time unpacking the race and the class imagery in this ad for buprenorphine. But I want to argue that this was just the tip of the iceberg. Okay, so this ad signals a radical shift in the image of who is addicted. And but this was just the tip of the iceberg. The whiteness of buprenorphine was actively achieved by specific social technologies. So I'm going to give you an analysis of the contemporary white opioid crisis in terms of what I call technologies of whiteness. So that is social technologies of neuroscientific metaphors, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies, which is an offshoot of critical race theory. And it proposes that whiteness is a category of exclusion, meaning in our society, not anyone can claim to be white and claim the benefits of whiteness. There's a lot of boundary maintenance. Cultural and political boundary maintenance. Second, white race is unmarked. So in the US, white race is the assumed norm for a quote unquote American, somebody with full citizenship. It's rarely explicitly named over the past century in public policies and in the media. When someone who's an American is mentioned, you can be assured that it's probably a white person. If race is mentioned, it's probably not someone who is white. And the more recent coverage over the past decade of whiteness in presidential politics, as well as in opioid deaths, has been the exception that proved the rule of the past century. So the second, and I will get into depth a little bit later about how white race to this day is often in the media signaled with coded language such as suburban, okay? And then 3, whiteness is defined by its other. So white on one hand and Black or non-white on the other hand are interdependent, and punitive American drug policy has long had a mutually defining twin of legal narcotics for white Americans who've had access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as suburban mother's little helper, now back to prescription opioid pain relievers. Finally, white privilege has its costs. Not only do white consumers pay inflated prices for newly patented prescription opioids, they pay with their lives in the form of overdose by lethal substances to which they have quote unquote privileged access. So the 4 the 4 technologies of whiteness that I'm going to be running through include addiction neuroscience, new biotechnologies, regulation, and marketing. And I'll start with the least visible of these technologies of race making, and that is addiction neuroscience. So we have to place buprenorphine development on the backdrop of President Bush the first's decade of the brain. This was the 1990s. It was an era in which National Institute on Drug Abuse was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. And in the process, NIDA renamed addiction a quote unquote chronic relapsing brain disease. And this was supported by leading NIDA researchers who co-authored this widely circulated article in JAMA in the year 2000. In it, they argued that that narcotics dependence was comparable to diabetes, hypertension, and asthma in terms of its heritability, treatment adherence, and relapse rates. And as such, it should be treated as a chronic medical disease. The scientists involved in this movement had a clear social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition and not a problem of morality or choice. But what they didn't anticipate was that scientific universalism, because it implied a standard white male subject, would open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. So for instance, brain images like this, by taking out the subject and his or her trappings of gender, race, and class out of the picture, by taking the offending organ, the brain, out of the body altogether, the image symbolically conveys an unmarked universality of addiction physiology. You don't know where this person comes from, who they are, and it shouldn't matter, right? It's universal, the physiology. Neuroscientists further reduced causation to molecular action at neuroreceptors, the ultimate disembodiment of addiction. The apparent universality of this molecular model implied an assumed white norm. It took a problem long associated with Black and brown crime and gave it a new implicit association with whites. But in the process, however, it excluded social conditions. The scientists involved wanted to counteract a drug war mentality by erasing the social context of drug use. But paradoxically, they set the stage for renewed racial stratification of addiction. Okay, the next technology of whiteness is new biotechnologies themselves. So neuroscientists unwittingly aided corporate strategists that capitalized on this erasure of the social. Building on the neuroscientists' ideology of technological solutions for addiction, in '96, Purdue Pharma got FDA approval for OxyContin as a minimally addictive pain reliever, suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush of oxycodone, the opioid, to the brain. The manufacturer influenced the National Joint Commission on Hospital Accreditation to call for pain to be aggressively monitored and treated as the quote unquote fifth vital sign, along with respiratory rate, blood pressure, heart rate. And drug reps advised new opioid prescribers as a further safeguard against abuse to direct OxyContin to quote unquote trustworthy patients. And they did this by handing out ads that portrayed white consumers of OxyContin in a national clinical workforce among American doctors that have been shown in studies to suspect Black and brown patients of drug use. So this implied white patients, trustworthy implied white. Of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. OxyContin users interested in a rush quickly learned to crush and snort or inject the oxycodone within each capsule. And after steep increases in overdose and non-medical use, public pressure mounted for intervention. In 2010, just as the patent on the original OxyContin ran out, Purdue Pharma introduced its tamper-resistant time-release formulation of OxyContin, which embedded oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them. So by keeping, in order to inject or snort. So by keeping prices high and representing OxyContin as technologically sealed off from misuse, manufacturers strove to keep OxyContin symbolically a step ahead of urban Black and brown street markets. So another biotechnology developed in response to the white, suburban, and rural prescription opioid epidemic is buprenorphine itself, combined with opioid antagonist naloxone and branded Suboxone, Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine is an abusable opioid, the naloxone with which it's manufactured causes withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, because naloxone can't be absorbed sublingually under the tongue. So buprenorphine, in addition to this, also posed a lower risk of overdose deaths than other opioids. In the 1990s, NIDA, National Institute on Drug Abuse, subsidized Suboxone's manufacturer with $23 million to test it for use in addiction treatment, sharply distinguishing it from methadone, and lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from narcotics Schedule II, which is where OxyContin and methadone fall, to Schedule III, along with codeine cough syrup. And this is what made it possible to prescribe Suboxone in private doctors' offices. The manufacturer also lobbied Congress to get Suboxone included under an orphan drug clause designed to promote pharmaceutical development for unprofitable diseases in low-income countries like malaria drugs. So Suboxone's designation as an orphan drug got it a patent extension through 2009 on a drug initially developed in the late 1960s. In a race and class stratified healthcare system like we have here in this country, where access to general doctors is often limited to people who can pay, patented, expensive technologies for private office delivery in themselves encode white race and middle class. Okay, the third technology of whiteness is regulation. So although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, arrest for their illegal possession for prescription opioids was 1/4 that for possession of heroin, and arrest for illegal sale of prescription drugs was less than 1/5 that of arrest for selling heroin. Not coincidentally, the non-medical use of pain relievers was twice as high among white Americans as Black Americans at that time in 2004. Oops. While the rates of heroin use among Black, Latinx, and white Americans were almost identical. Since suburban and rural white opioid users were not politically popular targets for drug law enforcement, the DEA and other regulators focused surveillance and enforcement on prescription opioid prescribers and pharmacists instead, and this led to the rapid spread of prescription drug monitoring programs now enacted in all 50 states, half of which mandate prescriber participation with threats of loss of license and prosecution for prescribers who don't check a statewide database before prescribing a narcotic to a patient to see if they're getting prescriptions elsewhere. So returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act passed by Congress in 2000, dated 2000, enabled any certified physician to prescribe Suboxone in the privacy of their own offices. In the congressional debates leading to passage of Data 2000, there's a clear emphasis on a, quote, new kind of drug user, one that is young, suburban, and, quote, not hardcore. So this is all coded language for white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction, end of quote. Then Health and Human Services Director Donna Shalala was but one of many officials who noted that buprenorphine as an alternative to methadone would serve, quote, a new kind of addict, including citizens who would not normally be associated with the term of addiction, end of quote. So with this racially coded language in which suburban and new kind of addict referred to middle-class white Americans, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So Data 2000 kept the restrictive methadone system intact. It did nothing to alter the drug laws that mandated inner-city heroin users to prison, but it did create a new treatment track for those with the resources to use it. And to give additional assurance to the DEA that buprenorphine would not spill over into illegal markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course, which some of you on this line may have taken. It's required for doctors to prescribe buprenorphine, And it was the first and only prescription drug in the US to come with this additional certification and training requirement. Public sector doctors tell me that the certification requirement in itself has been a major barrier to making buprenorphine available to low-income people because public clinics don't provide time or incentives to pursue certification. While prescribers in the private sector can charge fees of up to $1,000 for an initial half-hour buprenorphine induction visit. So the shortage of public sector prescribers, along with the cost of buprenorphine itself, have long kept buprenorphine in the private sector. So I'll go to my last technology of whiteness, which is ethnic marketing and media. OxyContin's legendary commercial success hinged on its designation as minimally addictive. When OxyContin was under review at the FDA, Purdue estimated the addictive potential of OxyContin to be less than 1% based on testing among terminally ill cancer patients for a 3-month period. In '96, the FDA accepted this claim, enabling Purdue to open an opioid market that had previously been restricted to people with severe acute pain like post-surgical pain or cancer pain. So they were able to open the market of patients with moderate chronic pain like lower back pain. And to do this, they hired 700 drug reps who canvassed a call list of 100,000 physicians in the first few years alone. So Purdue targeted general doctors in white, suburban, and rural areas serving patients that the public and the DEA did not think of as at high risk for addiction. And this strategy was very successful. It led to a 10-fold increase in prescriptions of opioids nationally, with disproportionate uptake of OxyContin and sister opioids, other extended release opioids that were marketed by other companies shortly after. Disproportionate uptake by prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. So in a newspaper content analysis that I conducted, I found that in contrast to articles about the criminality of Black and Latinx drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or people struggling with physical or emotional pain. And ironically, Purdue's technological response to the first wave of white prescription opioid overdose deaths, their tamper-resistant formulation of oxycodone, combined with new prescription drug monitoring programs like I just described, these two things together led many of these prescription opioid users to look for heroin on the illegal market when pills became harder to get and use. So one consequence of this was a whitening of the media coverage of heroin users who had long been portrayed as Black or brown. So this is a school teacher in suburban upstate New York, and this is a college athlete in Arizona, just two of myriad images that came out around this time. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet with manufacturer-sponsored websites like this one. And so you can see it features white professionals and business owners on Suboxone maintenance. This same website features a link to the Suboxone Prescriber Locator Service that was created by the Federal Substance Abuse and Mental Health Services Administration together with the manufacturer of Suboxone. So look in the lower left-hand corner, you'll see patients find a buprenorphine physician. There you put in your zip code and you get a readout, a printout of all of the buprenorphine certified prescribers in your area, the vast majority of whom will be in private practice. And these strategies together created an exclusive but lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion a year in the US alone by 2012. So just in that year, $1.5 billion in sales, second only in that year to OxyContin itself, which reported US sales of $3 billion in 2012. All right, so to conclude, this racial segmentation of drug markets into licit and illicit, white and Black, clinical and recreational. This creates a moving target of time-bound patents on new technologies targeting the white middle class. And this is an old cycle started by Bayer Pharmaceuticals' own heroin, which was marketed as a non-addictive alternative to morphine to middle-class white Victorian housewives in 1898. And it was also marketed as a highly effective cough syrup for their children. So what can we learn from this as clinicians, researchers, and policymakers? First, magic bullets are a myth. As the failed promises of OxyContin's sustained release capsule show, and the inability of unilateral buprenorphine expansion to stem overdoses has shown, biotechnology cannot stop the harms of narcotics without systemic and social intervention. And to underscore that point, I'm going to turn to an international comparison often used by American advocates of buprenorphine expansion, which is that of France. So in the country of France, where buprenorphine was adopted for general doctor treatment of opiate dependence in 1995, it was billed not as a stigma-reducing agent for a middle-class white market, but as a public health intervention to stem overdose and HIV among low-income, largely immigrant heroin injectors. As a result, buprenorphine was widely adopted among primary care doctors and poor communities in a country, and I need to underscore this, in a country with universal healthcare. So that's a very big difference between the US and France in terms of approving a medication for private office or general doctor treatment. The opioid overdose rate in France dropped 80% in the first 5 years after buprenorphine was introduced. Contrast this with the US, where opioid overdoses are now well over 6 times what they were in 2002 when buprenorphine was introduced. I bring us back to the graph that I showed in the beginning. And based on, and I'll go back to France. One thing that's not often mentioned in this country is that buprenorphine is delivered in a very different setting in France than here. So in France, a lot of it is delivered in community-based addiction centers that are quite comprehensive. They offer buprenorphine and methadone, they offer naloxone, reversal kits for overdose. They offer medical treatment for other health problems. They offer mental health treatment, and they offer, importantly, social services, assistance with housing, employment, childcare. They have peer navigators, people with lived experience of problem drug use who guide people through the process. They offer harm reduction services, not only syringe exchange, but also supervised drug consumption facilities. So I'm just painting a picture of a very different infrastructure and approach to healthcare in France in which buprenorphine is embedded. And that is likely responsible for their success, buprenorphine. The other thing I want to point out is if you look in the upper left-hand corner of this graph, you see the number 565 at the peak of opioid overdose in France. That's 565 deaths, period, in a country of 60 million people. So it turns out that France never had an opioid crisis of the proportions that we had. In the US, this number would have been closer to 565,000 deaths. So there was never a French opioid crisis in that way. Why? OxyContin and sister products were never approved for use in France. Why? Because an independent review body of experts who are prohibited from having relationships with the pharmaceutical industry prior to, during, and after service on this review body decided that OxyContin did not demonstrate clinical advantages or safety over the products that are already in use in France. So this should make us skeptical about, so in the US, by the way, many of the FDA officials who approved OxyContin went on to take lucrative jobs at opioid manufacturers afterwards. So this should make us skeptical about the power of the market to protect the public and rectify inequalities in health. In our for-profit healthcare system, buprenorphine maintenance has followed the pattern predicted by theorists of fundamental causes of disease, Bruce Link and Joe Phelan. And their prediction is that in a society like ours of very large social inequalities, if you introduce biotechnologies as a way to address inequalities in health, those technologies will generally widen rather than narrow health inequalities if the social drivers of health, the social inequalities, are not addressed. So buprenorphine has followed just this pattern. Okay, second concluding thought, problem drug use is biosocial. We should reconsider what it means that addiction is a chronic brain disease. Basic neuroscientists are increasingly seeing the brain as a plastic, socially responsive organ that's evolved to adapt to complex social systems. And emerging life science models of neuroplasticity, epigenetics, and the microbiome have underscored that human biology is not a fixed entity, but it's dynamically shaped in interaction with the environment. So these more sophisticated biological models, biosocial models, I call them, they call on us to invest in research on the impact of social systems and on interventions that create healthy social contexts, including robust social services and recovery support networks that give dignity, meaning, and structure to people's lives. So if we were to take seriously the comparison of drug dependence with diabetes, asthma, or hypertension that many of my colleagues in addiction medicine make, we'd have to recognize that each of these conditions, diabetes, asthma, hypertension, has strong social determinants, and that success in their treatment and prevention requires things such as social support, access to fresh foods, safe, unpolluted, walkable neighborhoods, the list goes on. So we have to approach addiction as biosocial as well. And then lastly, deaths of despair actually call for racial and economic justice. So back to this landmark article on the decline in US white life expectancy, its authors, and Case and Angus Deaton, were actually economists. So it's an unusual paper for clinical journals and bioscience journals because the authors were economists, social scientists, not epidemiologists. And their analysis of root causes of overdose, as well as suicide and cirrhosis among white Americans, lay not in neuroreceptors or genetics, but in the deindustrialization of the American Rust Belt towns, where the departure of manufacturing and mining industries has left behind high unemployment and social disintegration. So a sociological study that followed on their report showed that overdose rates were tightly linked to thin social networks in these areas. And accordingly, Case and Deaton have popularized the idea that overdoses are, quote unquote, deaths of despair. Okay, so this argument, deaths of despair, it's persuasive. It calls for social and economic revitalization through policies that promote social integration, stable employment with livable wages and benefits, and not just public-private partnerships to develop, quickly approve, and disseminate new medications and biotechnologies for addiction, as have been prioritized by federal initiatives like the NIH HEAL initiative and the Cures Act. But Case and Deaton's focus on white Americans makes the analysis incomplete, and it makes Black and Latinx overdose deaths invisible. Case and Deaton do not have a clear explanation for why Black and Latinx life expectancy did not decline in the time period of their study, but I want to propose that Black and Latinx Americans saw an overdose crisis 30 to 40 years prior to the timeframe of their study, with the influx of heroin to inner city neighborhoods from the 1960s to 80s. So blue collar workers in Black and Latinx neighborhoods were often barred from unions, labor unions, were last hired and first fired. They saw massive unemployment much earlier than their white blue collar worker counterparts who were initially protected by industrial discrimination. This earlier Black and Latinx opioid crisis was not seen as a health crisis. It was reported in the popular press as an epidemic of crime, leading to white flight from cities and further disinvestment from the Black and Latinx city neighborhoods that were suffering. So now we're seeing a second wave of Black and Latinx overdose deaths. And that has much to do with, number one, mass incarceration and the racially disparate profile of those in our jails and prisons who, when they're released from jail and prison in the weeks to months after their release, are at incredibly high risk of overdose. So incarceration itself is a risk factor for overdose because people who are coming out of jails and prisons have lowered tolerance. They're at very high risk for relapse. They have very few they don't have access to a lot of benefits as a result of their criminal record. They don't have access to public housing programs, a lot of other social services. They often don't have access to medical care, including addiction treatment. So it's an incredible, and then on top of that, these days, very likely to be exposed to fentanyl and other high potency, very toxic opioids that are now in the volatile street market. So while we work towards race and class justice in economic policy, we should use concern about the current overdose crisis, to go beyond drug development and to invest in number one, universal comprehensive healthcare, taking our lead from France, right? We need to include trauma-informed therapy, attention to psychiatric comorbidity, peer navigation, recovery support, assistance with housing and employment. And then second, we need to end criminalization of narcotics. You know, the heavy law enforcement around drug laws and drug policy, which continue unabated for Black and Latinx Americans. We need to do it nationally and promote harm reduction and treatment in its stead. Why do I say nationally? Well, there are places. So I recently came from New York City, where I spent 20 years. In New York City, in Staten Island, which is the city's whitest and most affluent borough, there is a program called Project Hope that redirects people who are arrested on low-level drug charges away from sentencing and towards treatment and partnering with a peer navigator. They've had tremendous success with this. The problem with Project Hope is it's not available in the South Bronx, which has a large number of Black and Latinx residents, and which has the largest number of overdose deaths in New York City. So if you leave it up to local initiative, you will get the most empowered communities taking the lead and leaving other communities behind. Third, we need much more attention in our clinical interventions and in our research to biosocial aspects of addiction and the systemic drivers of addiction. And so just some of the examples that we might look at include peer-based recovery networks involving the arts, urban gardening, and community-based organizations, including spiritual or religious organizations. So some of you may have heard my colleague Ayana Jordan's talk about her studies of placing addiction services in Black and Latinx churches. And she's gotten a very long way with that model because so many Black and Brown people distrust traditional clinics, especially those with a drug use history, because they've experienced so much poor treatment and discrimination in those settings. So placing addiction treatment in trusted community-based organizations such as churches goes a long way to engaging people, engaging their trust, and it changes the paradigm as people with lived experience also participate in treatment teams. So with that, I will open the floor to questions. Thank you.
Thank you very much, Dr. Hansen, for a very thought-provoking presentation. Does anyone have a question? You can unmute yourself and ask.
I was saying that it's a lot of material to absorb.
Dr. Hansen, what is your immediate advice, at least for our Department of Family Medicine associated with this issue? Thank you.
Okay, so how to move forward with the weight of all of this structural racism that I've presented. So I want to take the liberty of really quickly running through the slides that I didn't get to initially, because it'll just help me summarize an approach that I think has a lot of promise and that I think you're already implementing at Charles Drew in the Family Medicine Department. It's something that you and I, Dr. Bazargan, have already discussed and already written about together. And that is structural competency. So let me try to, so the structure in structural competency signals a shift from the paradigm that I was educated in of cultural competency as a way to address inequalities in health. So instead of paying attention to the cultural beliefs and behaviors of individual patients, which is what I was taught as a structural competency approach, it really asks us to look above the level of the individual patient to what are the structural drivers of inequalities in health. And what is our role as clinical practitioners in addressing those? And that's captured in a book. I've done a lot of publication and work with a growing network of colleagues around what structural competency could look like, but it's really an approach. And so this is one book that presents some examples, some cases of how people have implemented the approach in academic medical centers across the country. One thing that taking a structural competency approach really forces us to do is to understand what are structural drivers of health as opposed to social determinants. So we're more used to thinking of things like unstable housing as social determinants where we screen in a clinical encounter for whether someone has unstable housing. We rarely back up to ask why are certain populations or certain neighborhoods so much more subject to unstable housing. And for that, we have to understand housing policies at local to federal levels, such as urban renewal, planned shrinkage that deliberately raised low-income Black and brown neighborhoods and displaced people from their housing. So just as one example. And so structural competency, the word structure is borrowed from the social sciences to indicate that we have to look above the level of the individual. And I've just told a structural story, with opioids. And then competency, we have to, as clinical practitioners, participate in intervening at structural levels. These are the steps that I've outlined. And I'd say the hardest one is observing and practicing structural intervention, which is what we're busy doing together right now. Charles Drew and UCLA partnerships. And then developing structural humility, meaning this is about recognizing that we need to partner with people who have complementary expertise to ours. So in our clinical training, we don't know how to do community organizing. We don't get taught about health policy or public policy and how to advocate for policy change. But we can collaborate with people who do know those things and allow time, for structural change. And so I'll just end by giving a few examples of what this could look like using a rubric of different levels of structure that I've developed. So the first level of structure that we can intervene on as clinicians is the low-hanging fruit of what can we do right there in the clinic itself, where we already are. We can embed questions about social needs into the electronic medical record to remind ourselves to ask patients, do you have stable housing? Do you have legal involvement? We can also collaborate with law students or pro bono lawyers to have medical legal services so that when our patients have problems that are legal problems, but with big health consequences, and that's very common when it comes to substance use, that people are involved by definition with the criminal legal system, that we can help them with that too. Social prescribing is an approach where when we as clinicians identify a social need, we can actually write a prescription for assistance and help with that social need, such as assistance with applying for Social Security disability benefits, and then handing that prescription to a peer navigator or an organization that can help guide the patient through getting those services. And then I mentioned peer navigation. So peer navigators, community health workers as a part of the clinical team is increasingly popular. I know that Drew engages with peer navigators, and that is a profound structural change to the nature of the clinical team. The next level of structure at which we can intervene is collaborating with community partnerships or community organizations. And on the right-hand side is in the center is Ayanna Jordan. I already described her efforts to place addiction treatment in Black and Latinx churches. There are comparable initiatives in Native American spiritual healing centers to place addiction treatment, including medications there and combining them with spiritual healing approaches. Another level of structure is collaborating with non-health sector agencies or organizations such as housing agencies, legal aid organizations, schools, cultural arts centers, urban planners. And on that last note, this is a psychiatrist, Mindy Fullilove, who is my mentor. And she, after decades of studying the negative health impact of racial segregation in US cities, has set about to integrate US cities by race and class in collaboration with urban planners and architects. So for example, taking down the highway overpasses that were deliberately placed over the past century to separate neighborhoods by race and class, taking those down, replacing with common green spaces and urban and economic development zones for local businesses. So she says she's now a doctor, not of individual patients, but a doctor of cities, treating the pathologies of cities. And then lastly, policy. Okay, so I am an addiction psychiatrist working in the world of drug policy and its impacts. And I'm a member of this organization in the right lower hand corner, Punishment to Public Health, which is a collaborative of people like myself, practitioners, and criminal legal system officials, people with incarceration histories. They are working to redirect people from jails and prisons towards mental health care on many different levels, lots of different interesting examples. But the one I'll highlight is training clinical practitioners, physicians, and others to give testimony to policymakers about the health impact of things like drug policies. It's something we need to be trained to do. And this organization does that, along with training for writing op-eds. So this is my last slide, just an invitation to kind of join us as a group, as a movement. I hope I have time for another question as I hush my dogs.
Yes, you have time for one more question. Does someone have a question? You can
Yeah.
Okay.
Can I ask a question?
Absolutely.
Thank you very much for your wonderful presentation. So my question is back when you talk about one of the reasons that we have higher overdose among African American is after release. And definitely that is the case, but it's not limited to African American. And as you know, over the past few years, the proportion of incarceration decreased, not a lot, but a little bit. And that was the case over the past 20 plus years that African American had the higher rate of incarceration. So means what was the significance that now we have higher rate of overdose among African American recently, why we had the case of overpopulated African American in prisons? Means they got released every year over the past 20 years.
Yes, so you're so right about that. And so that's why I was highlighting the coupling of incarceration as a risk factor for overdose, which is very well established, with the emergence of fentanyl and high potency synthetic opioids on the illegal market. And there's a fascinating and complex story of how prescription opioids as the first wave, of opioid overdose deaths, with the laws, the prescription drug monitoring programs, and tamper-resistant formulations that I just described, leading to a heroin market to meet the needs of people who are newly opioid dependent but finding pills harder to get. And then these heroin markets then shifting into fentanyl markets. Fentanyl, it's 100 times as potent as heroin, making it easier to smuggle because you need a much smaller amount of it to have the same effect. So the cartels quickly turned to fentanyl as a replacement for heroin, as well as a whole host of other synthetic opioids. And we're seeing yet another wave now of stimulant deaths that are concentrated among Black and Brown Americans. Why would fentanyl, for example, disproportionately cause Black and Brown deaths? Well, one thing that my colleagues have demonstrated is that, for example, Black Americans are more likely to be exposed to fentanyl on the street markets. That has a lot to do with their position in the power hierarchy. The more power you have in our society, the more control you have over the source of your drugs and their safety. Okay, so that's number one. They're more likely to be exposed to fentanyl. And then we're still unraveling the increase in stimulant deaths among Black and actually Native American populations. Some of that has to do with a turning away from identified opioid markets. Some of it has to do with ethnic marketing of stimulants by the cartels to Black and Native American populations. But that's another way of really highlighting how racially stratified our drug markets are, both in the realm of legal pharmaceuticals and in the realm of street narcotics, and the ways that being in a lower position in the racial and economic hierarchy in our country puts you at increased risk. So I hope that answers your question, but this is a moving target. It's very dynamic. Those of us who work in this area can see that there are many trends that are fascinating to unravel over time.
Thank you very much. I appreciate your time.
Caroline, I'd like to say one thing. This is Plus. Thank you, Helena, for your presentation. This is Miss Plus from Community Faculty. I just want to make a statement. Community faculty is different from community health workers. Community faculty are people that live in the community, and we bring in life experience. Community health workers are people that went to school to learn how to be health workers. So I just want to make that distinction, because we are totally different. We live in the community, we bring life experience to Charles Drew, and the others had to learn how to live, how to learn what I said before. So I just want to make that distinction.
Thank you. And
Thank
Charles
you.
Drew really stands out as a place that has both. You know, very few institutions can count that they have both community faculty and community health workers.
Well, no one has
Amazing.
community faculty. We are the ones.
Right.
But thank you.
Thank you very much, Ms. Pless, and
Thank you,
thank you.
Caroline.
You're welcome. And thank you again, Dr. Helena Hansen, for joining us today. And on behalf of Dr. Carlisle, our faculty, and our staff here at CDU, thank you for being our featured speaker today, and have a great day.